a few more minutes and we'll start. Right, so today's session, we're going to be doing the first part of a thorax, and we're going to be trying to cover the most important parts, so the things where you find most questions. We're going to be covering the thoracic wall, the diaphragm, and the mediastinum. So hopefully in the next lecture, we'll be covering the pleura, lungs, and heart. So yeah. Throughout the lecture, you'll see starred titles. If the title has a star on it, it means it's more likely to be in the exam than the rest of it. It's going to be the part we're going to be focusing on. يعني أي حاجة فيها star is more likely to be on the exam, or it's more important for the exam. Okay. Right. So when it comes to the thoracic wall, so when it comes to the thoracic wall, the first thing you guys need to know is what it consists of. So it consists of posteriorly the vertebrae, anteriorly the sternum, and then there's the ribs and the intercostal spaces, including the neurovascular bundle, which has the vessels, arteries, and nerves, and also the intercostal muscles. Okay, so thoracic vertebrae, ribs, sternum, intercostal space, intercostal muscles. Now, most of the exam questions usually either focus on the ribs, on the sternum, or on the vessels and arteries and nerves. It's very rare that you find questions in the exam, and if in MCQs, about the intercostal muscles. And even we can say the intercostal space is also rare. So most questions هتيجي في bones ذاتها في thoracic vertebrae, ribs, or sternum, mostly rib and sternum. Well, so for the sternum, the things that they ask about the most is a location, or the surface anatomy of it, so that the manubrium starts at T3 and ends at T4, that the body starts at T5 and ends at T8, that the xiphoid process starts at, is at T9. That's one thing that you need to be very familiar with. Another thing you need to know about the manubrium is that it attaches, what structures it attaches to, and the types of joints. We're going to be discussing the joints in a bit, but you need to know that it attaches to the clavicle, it attaches to the first rib and the first part of the second rib. Other things you need to know is, as I said, the joints. So all of the joints are very important, especially in the DR exam, because they ask a lot about the joints. The jugular notch is also sometimes asked about, but not really that much. في أي kind of question related to the sternum in any form? Okay, so ما سامع دقيقة let me check. Can you all hear me? في زول ما سامع؟ واضح. Okay. So as we already
الأونلاين بدأ بعد ما يبدأ في الكيس.
Okay, so sorry. Okay, so next we're going to be talking about the thoracic vertebrae. And when it comes to the thoracic vertebrae itself, in the DR, it's important to tell the difference between the different vertebrae. So like they wouldn't ask you about details, they just ask you to identify. And يعني, again, في like semester 4, most of their questions would be about the atlas, the axis, and these ones, the head and neck vertebrae. However, يعني في ال MCQs, they do ask about the pedicle and the lamina, which are structures or areas that are found in the thoracic vertebrae. So the pedicle is the area between the body and the transverse process. So it's here. And the lamina is the area between a transverse process and the spinous process, which is here. And the lamina is the one that's usually asked about because it's clinically important. It's the weakest point for a vertebra, and it's cut during surgery. So it gives you easy access during surgery. So sometimes they would ask you about the lamina, like otherwise they don't usually ask a lot about the vertebra. No? In some cases, if they're being extra mean or like the extra detailed, they could ask you about the articulation of the joints of the vertebra, but برضو it's usually not that much. Usually they focus on the joints with the ribs, with the sternum. Huh? Okay, so the thing we're going to be discussing in most details here is going to be the ribs, the classification of the ribs, the joints, and all of these details, because this is where most questions in thorax are there. There you can find it in DR, you can find it a lot. So أول حاجة classifications of the rib. So the classification is due to two types. We either classify it due to attachment, or we classify it due to shape. So the first classification, which is due to attachment, we've got classifying them into true ribs, false ribs, and floating ribs. True ribs are ribs that directly attach to the sternum, as you can see here. The first 7 count as true ribs, these ones. They attach directly to the sternum. Then we have false ribs. The false ribs don't attach directly to the sternum. They first attach to the costal cartilage above them, and then that costal cartilage will attach to the sternum. So for example, 8, 9, and 10, these 3, instead of attaching directly to the sternum, they will attach to the costal cartilage above and then onto the sternum. So these are false ribs. The floating ribs don't attach at all. So they're the last 2, and they're usually just found in the back, so they don't reach the front. And these are sometimes asked about. The questions aren't difficult when it comes to ribs. The classification based on attachment. The classification based on shape. And when it comes to that, we refer to them as typical and atypical ribs. And this is where it's very confusing at first, and it takes time to memorize. And also, it's a very good area of questions sometimes. So the criteria for what makes a rib typical or atypical, first, we got the presence of a head that has 2 articular facets. Okay, so the head has to have 2 articular facets. I'll show you guys a picture in a bit. And the articular facets are supposed to attach to the rib above above, and the corresponding vertebrae. The second thing is that it has to have a neck. The neck would have attachment for a ligament, the costotransverse ligament. The third criteria is that it should have a tubercle for the attachment of the transverse process. Fourth, that it should have a shaft. 5 is that it should have an angle. And 6 is that it should have a subcostal groove. Okay, so these are the things that you always need to see in a rib so that you can call it a typical rib. No? So we can look at these ribs here. We've got rib number 1 and rib number 2 to show you guys the typical versus atypical. Now, rib number 1 and 2 are both atypical. So I'll be showing you guys what's missing as well as what's extra. So usually it should have a head that has 2 articular facets. Here, you can see the head and the articular facets 1 and 2. Although in the first rib, there's only 1 articular facet. So it doesn't count as a typical rib, okay? The second thing is that the neck should have the costotransverse ligament should attach to the neck. The third thing is a tubercle, which attaches to the transverse process. A shaft an angle, and a subcostal groove, which is underneath it, that has the neurovascular bundle, which are the vein, artery, and nerve. Tamam? So something that's very important is to know that, sorry, I'll just think. Sorry, I got interrupted. But sorry. Okay. But last thing I was saying was that, it has to have these 6 criteria for it to be called a typical rib. And if it has anything that's missing or anything that's extra, it would be called an atypical rib. So a lot of the questions usually are in the first rib specifically, because it has one articular facet only, simply because the rib would only attach to T1. There is nothing above T1. It doesn't attach to the C, the cervical vertebrae. It also would be missing, it has an extra tubercle, which is basically a tubercle that is for the attachment of the scalene muscle. So it's called the scalene tubercle. And it has an additional groove for the subclavian vein. So these things make the first rib atypical. The second rib is also atypical because the shaft.
Yes? Can you please repeat?
Okay. Right. So the last thing, basically, we're talking about the classification of the ribs and how to classify rib from typical or atypical based on the shape. Come on. So you either call it typical or atypical. Call it typical if it has those 6 things. Come on. And you call it atypical if any of these 6 things are missing, or if one thing is extra. يعني نزيد لها حاجة بتبقى atypical. ننقص حاجة من ال6 ديل بتبقى atypical. So the 6 things are, it has to have a head with 2 articular facets. يعني the head of it here on the beginning has 2 facets, not one. It has a neck, and the neck should have a costotransverse ligament. A ligament هنا ما ظاهرة, لكن usually it's just attached. They don't ask much about it. It should have a tubercle for the transverse process. This tubercle here. It should have a shaft, and the shaft should be flattened. It should have an angle that's here, and the angle is usually the weakest rib, which is most likely to be fractured. I think I remember one time they asked us about that, like which part is more likely to be fractured. So it's the angle. And then last thing, it should have a subcostal groove, and the groove should have the neurovascular bundle. So it should have intercostal vessel, artery, and nerve. Tamam? So if the rib has all of these 6, we'll call it a typical rib. If the rib has any of these that are missing or one thing that's extra, it'll be called an atypical rib. Tamam? So the typical ribs are ribs number 3 to 9. So 3 to 9 are typical. The atypical are 1, 2, 10, 11, and 12. Okay? So the reason why 10, 11, and 12 are not typical is, if you can think about it, remember that 10 and 11, the rib below them is a floating rib. So rib number 12 or rib number 11 are floating, صح? So that means that they don't form a full intercostal area. So it doesn't have a full intercostal space, which means that the intercostal groove would not be complete. Or it would not have the vessels all the way till the ending. So that makes these 2 atypical. The 12 is atypical for all reasons. It's atypical because it doesn't even have a subcostal groove at all, because it doesn't have an intercostal space below it. And it's very short. Actually, it's a floating rib. And it only has 1 facet because there is no thoracic vertebra below it. and it has no tubercle. يعني 12 دي almost has none of the criteria. And 11th and 10th, as we said, they don't have a full subcostal groove. And the other problem is that the 10th and 11th also don't have a tubercle. So no tubercle and no subcostal groove in the 10th and 11th and 12th. The 12th has extra things such as no, the head has only one articular facet. So these are the features that make the 10th, 11th, and 12th atypical. The first and second are also atypical. The first one, as we said, it has an extra tubercle called the scalene tubercle. That's for the attachment of a head and neck muscle called the scalene anterior muscle. And it has a groove for the subclavian vein. There's also the second rib. It should, for me, I think it's typical, but they say it's atypical because the shaft is not flattened, which is like, I mean, if you say typical or atypical, they wouldn't really bother with asking you about it much because it's debatable, if that makes sense. Tamam? Makes sense, ya jamaa? Any questions?
No.
Do you have a question?
No.
Okay, tamam. Thank you. And we're gonna go to the next picture. So next we're gonna be talking about the joints. So after we talked about what the ribs are and where they attach, now this is like the most important part, where to recognize the types of joints and the names of the joints, because it's most area for questions in both the DR exam and the MCQs exam. So how do you have the manubriosternal joint? And the manubriosternal joint is secondary cartilaginous. And if it's the xiphosternal joint, but the xiphosternal joint is also secondary cartilaginous. However, in old age and above the age of 40, it becomes primary cartilaginous. So they can ask you, they can mention this. The xiphosternal joint, after old age, or age of 40 and above, it starts to ossify, outfuse, and it becomes primary cartilaginous. So these are secondary cartilaginous and primary cartilaginous joints are joints that have very minimal movement, so they don't move that much. And if you're starting to think about it, you'll know you don't really need to move your manubrium or your sternum, right? So therefore, it means it's not really needed for it to have movement. Unlike the costovertebral joint, the costochondral joint, we're going to talk about in a bit, you need to move them to expand your chest. صح? طيب. So next is the costovertebral joint. So it's a joint between the rib and the vertebra, and these ones are synovial joints, so they can move. And there's also another joint, which is a joint between the tubercle and the rib itself. And if the costovertebral data, we split it into two: the joint of the vertebra with the rib, and the joint of the tubercle with the transverse process. And it's also synovial joint. So they're both synovial joints. The joint حقت الvertebra مع الرib, and the joint of the transverse process of the vertebra with the tubercle of the rib. So there's two, and they're synovial, both of them. We also have the costochondral joint, which is between the rib and the cartilage.
in the sternum, صح?
And costochondral is between the rib and the costal cartilage حقه. While a sternocostal is between the sternum and the rib. So the costochondral, it's primary cartilaginous. And again, we don't really need to move it. While it's sternocostal, which is between the rib and the sternum, is the one that needs the most movement. So it's synovial. يلا هنا في one extra trick إنه first rib is an exception. The first rib is not a synovial joint, it's a primary cartilaginous joint. As I said, this to remember it, and the best way to remember it is to just think, do I need to move it or do I not need to move it? If you need to move it, it's a synovial joint. If you don't need to move it, it's a cartilaginous joint. تمام؟ يعني المنوbrious sternum, think, do I need to move my sternum from the body of the manubrium? يعني the body from the manubrium? No, so it's secondary cartilaginous. لكن do I need to move the vertebra and the rib or the rib and the sternum? And the answer is yes, because you need that for chest expansion and to breathe. صح? So that means it's probably going to be a synovial joint. Make sense?
Postchondral.
تمام you guys?
Yeah.
طيب. So right. So again, as I said, you need you guys just be paying well attention to the joints. Danny, the thing that you get really asked about like the most is structures that are found behind the manubriosternal joint and the location of the manubriosternal joint itself. The manubriosternal joint is found at the junction of T4 to T5. Okay? And sometimes this event that happens at T4, T5, they say the patient, for example, got a knife stuck between the manubrium and the sternum, the body of the manubrium and the manubrium and the body of the sternum, how that they had an injury at the level of T4, T5 or a gunshot or something. يعني دائما تلقاه في البيبر حق الكلينيكال. And they'd ask you what structure is most likely to get damaged. So in this situation, you have to know what structures are found right behind the manubriosternal joint. And the most common structure that's going to get damaged, or the structure that's right behind it, is the arch of the aorta. So there's the arch of the aorta, there's the bifurcation of the trachea, the bifurcation of the pulmonary trunk, there's the esophagus, the thoracic duct, and the zygous vein. And specifically, the zygous vein would be entering into the superior vena cava. تمام? So دائما بيكون في questions about the they're mentioning the manubriosternal joint and a structure that got damaged behind it. So you'd think of these 6 specifically. No? So it's a very high yield topic, very high yield and very common in exams to be asked about what would happen or what would get damaged if you were to injure your manubriosternal joint. And the most common answer is the arch of the aorta. If you can't find the arch of the aorta in the options, then look for the other ones. But usually the answer is usually the arch of the aorta. So far, any questions, Danny? Like, if you guys have any problem or any questions, just stop me at any time. Right. Next, we have the intercostal spaces. Well, intercostal spaces, again, the questions aren't that much about it. Like, it's good to remember it. You need to remember where the veins and arteries and nerves come from. So أكتر حاجة usually it's the arteries, the blood supply of the intercostal spaces that's asked about. The rest is not that much. No? So أول حاجة to really just remember is that the amount of intercostal spaces posteriorly is not equal to the same intercostal spaces anteriorly. If you count the intercostal spaces from the back, they're 11. Now, floating ribs, they start from the back. لكن anteriorly, the floating ribs don't reach the front. صح؟ عشان كده anteriorly, there are only 9 intercostal spaces. Right? So the total amount of intercostal spaces anteriorly is 9. لكن the total amount of intercostal spaces posteriorly is 11. تمام؟ Right. So after that, any question? Okay. So posteriorly, intercostal arteries, the first two have a different rule than the rest. The first two posteriorly are from the superior intercostal artery. And that superior intercostal artery comes from the subclavian artery, you know? Specifically from the costo-cervical trunk of the subclavian artery. It's not that important to know that detail, except in a branch of the subclavian artery. And the first two posteriorly take the blood supply from the subclavian artery, while the rest take it from the descending aorta. And blood supply of the posterior intercostal spaces is the first two from the subclavian, والباقي or the rest is from the descending aorta. While anteriorly, the first 6 spaces would take it from the internal thoracic artery, which comes from the subclavian again. And the last ones, the internal thoracic artery would split into 2 arteries, the musculophrenic artery and the superior epigastric artery. And so the last 3, would take from the musculophrenic. So it's an area of questions. So I'll repeat it again. The posteriorly, the first 2 intercostal spaces would come from the superior intercostal artery, which is a branch of the costo-cervical trunk, which is a branch of the subclavian artery. While the rest would take from the descending aorta directly. And it's important to know that these are just each intercostal space would get only 1 branch from the each. And back to the back, there's 1 branch each. anteriorly أيوة.
ممكن تشرحيهم يعني من الأول من فوق، فهماني؟ من
تمام.
السبكليفيان كده.
خلاص تمام. طيب posteriorly بورا أول حاجة تحصل السبكليفيان artery بيمرق منها branch اسمه costo-cervical trunk، والcosto-cervical trunk ده تاني بيدينا branch اسمه superior intercostal artery. superior intercostal artery دي بتدينا branch ل the first 2 intercostal spaces. تمام؟ بعد ذاك من نمرة 3 وانت نازلة it would be from the descending aorta هنا. So descending aorta would just give you a branch لكل space. ده posteriorly. Anteriorly بنشيل برضو من السبكليفيان vein حاجة اسمها internal thoracic artery. internal thoracic artery بتنزل anteriorly وبتدي لنا كل intercostal space. لما تصل intercostal space number 6 it would split into 2 into the musculophrenic artery وال superior epigastric artery. The musculophrenic would supply the last 3 intercostal spaces. تمام؟
تمام.
Can you repeat the anterior again? The last 3 musculophrenic.
Okay, tamam, sure. Yeah, so after the first 6 take from the internal thoracic, the internal thoracic would split into 2, musculophrenic and superior epigastric. And musculophrenic, it would go and supply the last 3. Right? The superior epigastric is the abdomen, so we don't care about it right now. Huh? Okay, so the veins. The veins are a bit trickier than the arteries. So the arteries, it was simpler. See the veins? نبدأ برضه بالposteriorly ولا نبدأ بالposteriorly برضه anteriorly because it's easier. So anteriorly it's the same as the arteries. So the first 6 من internal thoracic vein والlast 3 من musculophrenic vein. تمام؟ Exact same. They drain into the musculophrenic vein, and then it goes up and it it joins with the superior epigastric to form the internal thoracic vein, and then the rest, the first 6 intercostal spaces would drain into the internal thoracic vein. So it's the exact same as the anteriorly on the arteries. The vein posteriorly is a bit confusing, so I'll take my time, and I need you guys to ask me to repeat في أي second that you don't understand. تمام؟ So posteriorly إننا أول حاجة الفيرست سبيس براها والسكند and third سوا والباقي سوا. تمام؟ So the first space it drains into حاجة اسمها vertebral vein. تمام؟ أو it drains into the brachiocephalic vein. So it could sometimes drain into the vertebral vein and sometimes drain into the brachiocephalic vein. It varies and it's not stable.
Ma'am,
أيوة.
I'm sorry, can you repeat the posteriorly again?
Yeah, of course. Okay, so the posteriorly, it has a different rule for each space almost. So the first space, it either drains directly into the vertebral vein, so in the neck, or it can drain into the brachiocephalic vein. Okay? Then the second and third space, they have their own rule. So the second and third space, they would drain into the brachiocephalic vein or the azygous vein, depending on whether they're right or left. If it's right, it drains into the azygous. And if it's left, it drains into the brachiocephalic. Okay, so that's why it's a bit confusing, because you have to memorize the right and the left. So the first space drains into the vertebral vein or the brachiocephalic vein, regardless of whether it's right or left. But the second and third, the right one drains into the azygous, while the left one drains into the left brachiocephalic. Then after that, the rest would drain into, if it's the right, it would drain into the azygous. If it's the left, it would drain into the hemiazygous. So if you can look at here on this drawing here, this is the azygous vein, and this is the hemiazygous vein. It's on the right side, it will drain directly into the azygous vein. It's on the left side, it will drain into the hemiazygous vein. However, the azygous vein doesn't go above the 4th intercostal space. So if the rib is on 1, 2, or 3, it can't drain into the azygous. It'll have to drain somewhere else. So if it's the first one, it'll drain into the vertebral vein or the brachiocephalic vein. Or if it's the second and third, it'll drain directly into the brachiocephalic vein. Tamam?
You wrote right azygous, LT. What do you mean by LT?
Oh, left. Right is for azygous and left is for hemazygous. It's one here. So right is in the azygous and the left is in the hemiazygous vein. تمام؟
قلت الأزايجوس ماله؟
الازايجس هندا it drains فيه الرايت سايد والليفت it drains فيه الهيمي ازايجس. تمام؟ يعني on the right الانسر ازايجس، لكن قالوا لك on the left الانسر هيمي ازايجس. تمام؟ Now the most the most important part to get out of this is this part, موضوع الازايجس والهيمي ازايجس. Like it's the area where there's most questions. They rarely ever ask about the first space or second or third space. They usually ask about the rest of the spaces. So the right side is on the azygous vein, while left side is in the hemiazygous vein. No? طيب يا جماعة.
تمام.
طيب في تاني الانتركوستال نيرف. يلا الانتركوستال نيرف دي فيها كلام كتير. However, there's barely any questions ever about it. So I'm going to be going through it very lightly, hopefully. And if you guys have a problem with it, don't bother too much. It's برضو I don't know if I should give you guys should I mention it in details ولا أحسن نمشي فيها خفيف زي. What do you guys think? then I don't want to capture it. It's not that important, to be honest. It's not that important. It's barely ever asked about. في الارتري والفين.
Okay.
نخليها أحسن صح؟ لأنه it's a bit confusing and I don't want you guys to sit and memorize it when you could like use the time to use it on a better topic صح؟ فهخليها النيرف. If anyone is just curious and wants to know about it ممكن في the ending of the lecture I can explain it لهم تمام؟ فهنمشي للdiaphragm طوالي. في أي دول عنده أي question في الباقي الفات we talked about from the beginning the thoracic wall.
Can you mention again why does the posterior intercostal space are 11 while the anterior are 9?
Okay, yeah, okay. So if you can see this picture here, in the posterior part, in the floating ribs, صح? So the floating ribs are there and they form the intercostal spaces in 10th and 11th. But anteriorly, the floating ribs don't reach the front. So from the front, ما في floating ribs, ما في 2 extra ribs. The last rib on the front is the 10th rib.
Okay.
So that's why there's only 9 intercostal spaces anteriorly, while there's 11 posteriorly. Now floating ribs don't reach the front, they're only in the back.
Okay.
Tamam? Makes sense?
Yes.
Okay, tamam. So I think you guys, I think we should take a short break before we come back to the diaphragm. We could come back at like 7:45 كيف معكم?
Okay.
Okay,
Thank
so
you.
Okay, that's good.
we'll start again at 7:45.
Thank you.
Thank you guys.